Hello, everyone. I would like to welcome you to our webinar, which is entitled The Hidden Sleep Crisis: Environmental Factors Robbing Communities of Rest. My name is Dr. Dayna Johnson. I am the Rollins Distinguished Associate Professor of Epidemiology at the Rollins School of Public Health at Emory University, and I am your moderator for today's panel. We are here today because there are millions of individuals that are experiencing poor sleep health and sleep disorders, not because of their individual choices, but because of the environments in which they live, which we are referring to as sleep deserts. Epidemiologic evidence shows that depending on the stage of life, that between 35 and 75% of individuals report insufficient sleep. And many of those individuals are living in neighborhoods that are hostile to sleep. And so this is contributing to the sleep disparities that we are seeing. And so that brings us to this urgent need to address and understand the different environmental factors that are contributing to poor sleep health in our society. And so, based on the evidence, there are different environmental sleep disruptors. So, we see that noise pollution, light pollution, air quality, and different features of the social and built environments, including social cohesion, neighborhood violence, disorder, intersection density, and population density, is affecting sleep health. And so most of the evidence that we have observed is based on observational data. But there are recent interventions that are addressing the environmental factors that are contributing to poor sleep health, many of which, or one at least, we'll hear about today. And so here's just some of the evidence or papers that we published, my colleagues and I, coining this term sleep deserts. And because of our last article, which was published in Sleep Health, addressing addressing sleep deserts, a proposed call for action, led to the special issue on sleep deserts, which is featured in Sleep Health. So I want to acknowledge my co-guest editors for the issue, Doctors Kristen Knudsen, Harar Artarian, and Lauren Hill. So together we reviewed many articles. So thank many of you for submitting to Sleep Health your evidence on sleep deserts. And so we selected many phenomenal articles that are now featured in this issue. And so I also want to acknowledge the team that really helped shape the issue. So Orfeo Buxton, Amanda Applegate, and Amber Neef. And so here is the editorial that we wrote that you will see in the special issue, where we're summarizing the evidence that was published in the special issue. And so for today, we will hear from three of those speakers that are featured in a special issue. And so we selected these articles to highlight the different aspects of the research that we're seeing now. So some observational and intervention study looking at different features. So the first one, we'll have Dr. Jing Wang present on evidence looking at air pollution, followed by Dr. Phil Cheng, who will talk about some of the pathways that we're seeing, how neighborhood social vulnerability is mediating racial disparities in insomnia severity. And then we will finish with Dr. Wendy Troxel, who'll give us some evidence or show us the evidence that she has collected and her colleagues on intervention to address these different environmental barriers in order to promote sleep health. So each of the speakers will present for 10 minutes, and then we'll follow that with discussion. So you can add your questions to the chat, but please use the Q&A feature, and I will select different questions that we will present to each of the speakers. So thank you again for attending. I'm really looking forward to a robust discussion about sleep deserts. So we'll go ahead and proceed with Jean's presentation. So please share your screen.
Yeah, thanks for the introduction, and Can everyone see my screen?
Yes, we
Okay,
can.
cool. Yeah. So good afternoon, everyone. I'm Jing, and thanks for the opportunity to let me present our research findings regarding the associations between indoor fun particulate matter and pediatric sleep disorder breathing. And to give a brief introduction, pediatric sleep disorder breathing, or SDB, is a general term that describes the difficulty of breathing during sleep, and it includes a wide range of the symptoms. And previous studies have shown that pediatric sleep disorder breathing is prevalent in children living in the disadvantaged neighborhoods and is associated with multiple risk factors, including disadvantaged race, ethnicity, low socioeconomic status, poor air quality, genetic predisposition, and some health conditions like obesity and asthma. And among all of these risk factors, I want to point out the air pollution, or in particular the PM 2.5, which is defined as the particulate matter with the diameter less than 2.5 micrometers, which has been classified as the group 1 carcinogen to human and has been linked to a wide range of the adverse health outcomes, including like respiratory disease or cardiometabolic diseases. And also previous studies have shown that a higher level of the outdoor PM 2.5 exposure is associated with higher SDB risk. However, although associations between the outdoor PM 2.5 and SDB have been previously studied, the influence of the indoor PM 2.5 is still unknown. And we can see from this figure that the sources of the outdoor compared with the indoor PM 2.5 is pretty different. We can see from the left hand of the figure that the outdoor PM 2.5 source are mainly from the chemical reactions of the gases in the atmosphere, the combustion of the fuels and oil, and also the vehicle emissions, as well as some nature disasters like the wildfires and dust storms. While for the indoor PM 2.5, it can come from both outdoor and also indoor human activities like tobacco smoke, cooking activity, and the use of the cleaning products, fireplaces, and also candle or incense use. So given there are so many different regarding the source for the outdoor and indoor PM 2.5, and the majority of our time are spent actually indoor, so our study want to investigate the association between the indoor PM 2.5 exposure and pediatric sleep disorder breathing. So our study population are the 261 children aged from 6 to 12 years old living in the predominantly low socioeconomic status neighborhoods in Boston, Massachusetts. And we measure our indoor PM 2.5 exposure by the portable environmental multi-pollutant monitoring assembly. And we put this kind of equipment in the participant living room for 3 days, and we then calculate the 7 days. And then we calculate the 7-day average indoor PM 2.5 levels. And then we further classify those who exposed to the elevated level of the indoor PM 2.5 as those with the threshold of the 80th percentile of the sample distribution, which is 15.6 microgram per cubic meters. And this number is aligned with the WHO's 24-hour threshold for the guidelines for the ambient PM 2.5 level. And our primary outcome is the sleep disorder breathing, which has been defined as the harmonized apnea hypopnea index and oxygen desaturation index with over or equal to 5 events per hour with the scale of the 3% desaturation. And it was measured by the watchpad or finger pulse oximetry by the one-night home study. We also consider the habitual low snoring as our secondary outcome, and we define this kind of outcome as the caregiver reported snoring with most or all the time over the last 4 weeks. Then in terms of the statistical analysis, we are using the logistic regression primarily adjusted for age, sex, race, ethnicity, household income, and seasonality in our model. So here is the sample characteristics of our study. So we can see the mean age of our sample is 9.6 years old, and 41% of the sample are females. The majority of our sample are Hispanic children, and there are also 29% of the are non-Hispanic Black. In terms of our outcome, we have identified 32% of them having the being defined having the sleep disorder breathing, and we also found 8% of the sample had the habitual low snoring. Then in terms of the PM2.5 exposure, our data show that the medium of the average daily indoor PM2.5 is 7.4 microgram per cubic meters. And we also found the outdoor PM2.5 is slightly lower than the indoor PM2.5 exposure, which is 6.8 microgram per cubic meters over the study period. Here, I would like to share our main findings that we can see from this figure that children exposed to higher indoor PM2.5 levels have around 3 times increased odds for the SDB compared to those with lower indoor PM2.5 exposure. And we can see after we adjust for different set of the covariates, including the health condition like asthma and the BMI percentile, as well as the neighborhood socioeconomic status using the Child Opportunity Index as a proxy, and also different sources of the indoor PM2.5, like the environmental tobacco smoking and daily average outdoor PM2.5. We can see the results are showing pretty consistent results across the different statistical models. And similarly, compared to the SDB, we also find exposed to higher level of the indoor PM2.5 were associated with higher odds of the habitual low snoring. But although the results do not show statistical significance, but we do find some signals regarding the association between indoor PM2.5 and the habitual low snoring. So in conclusion, our study found that children with higher indoor PM2.5 exposure had greater odds of the sleep disorder breathing, and our study also have several implications. For example, we have in our study around 20% of the children were exposed to the indoor PM2.5 level that exceed the WHO's 24-hour threshold, as I mentioned before, which is 15 microgram per cubic meters. And but it's notable that the PM2.5 exposure in the future will likely to be increased due to the climate change. For example, we can see due to the recently higher frequency of the wildfire, the exposure to the ambient PM2.5 will definitely be increased over this period. And also due to the increase of the temperature and the humidity due to climate change in the future, the filtration rate from the outdoor air to our indoor will also be increased. That implies that our indoor PM2.5 exposure will also be likely to increase in the future. So that implies the association we have been found will likely to be exacerbated by the climate change in the future. In addition, our study also supports the importance of the indoor environment as a contributor to the pediatric sleep disparities. In particular, we shed the light to the indoor PM2.5 level. So definitely there is a need to have the indoor air quality be addressed as a modifiable risk factor. For example, there are several ways to approach this, like develop some interventions, like give the parents some educational intervention, or improve the housing environment, like improve their ventilation system in the kitchen, as well as develop some regulation, particularly targeting for the indoor air quality, as most of the existing regulation for the air quality are most for outdoors, but we definitely need more regulation and guidelines for indoor air quality. And finally, I want to thank for my mentors and all the EASY study investigators, as well as our fundings. And I'm also happy to take any questions at the end of the discussion session. And feel free to read our full manuscript in the website of the Sleep Health Journal. Thanks for your attention. And that's all my today's presentation.
Thank you very much. Now we'll move to Dr. Cheng.
All right. Okay. Can you confirm that you see the slides?
We can see them.
Beautiful. Well, thank you so much for the invitation to be here and to talk about our paper, Neighborhood Social Vulnerability as a Mediator of Racial Disparities in Insomnia Severity. So to start off with, we know that when insomnia occurs in racial minorities, it's often more severe compared to their white counterparts. So some of our earlier work has shown that in racial minorities, we see a 60% increase in insomnia disorder with short sleep, which we know is the sort of most severe phenotype based on Julio's work. We also know that racially minoritized individuals are 2 times more likely to exhibit chronic insomnia. And so this represents a disparity that we're very much interested in part because we know that poor sleep is a robust predictor of poor health, and in this case, poor mental health. And so far, a lot of the extant work has really presented a pretty easy to understand and simplified model where we can look at white versus non-white individuals and see if the relationship between poor sleep are differential between the two groups, but also differential in its predictor of outcomes that we also care about, including poor mental health. Now, the problem with using that framework is that we know that race is really not a determinant, but rather a proxy of some of the determinants that impact both sleep and mental health. And so really that requires us to change our framework and thinking and really think about sleep as being embedded within a socio-ecological framework that includes individual factors, but also social and environmental factors. And indeed, what we know is that when we've looked at insomnia severity and compared it by, on the left-hand panel, racial categories, as opposed to, in this case, on the right-hand panel, discrimination, experiences of discrimination, you can see that the degree of difference is much larger when we parse these groups by social determinants of health, in this case, discrimination, as opposed to their racial categories, which suggests that these are more robust and meaningful ways of understanding the phenomenon of disparity. So in our current paper, we were really interested in pushing past social determinants of health and getting to structural determinants of health. And in this case, we wanted to ask the question, what role does place or neighborhood play in an insomnia severity? And to do that, we looked at something called the Social Vulnerability Index, which is originally developed to determine allocation of resources during natural disasters. So this is a way of ranking how well resourced a particular census tract is along 4 main domains. Here you see socioeconomic status, household composition and disability, minority status and language, and housing and transportation. Under each of these are 16 individual components as well, but these all get sort of aggregated into an overall vulnerability score. And so we surveyed just under 200 individuals with verified insomnia diagnoses. And this is the distribution across the country. So you do see in the Detroit area, which is where we are located. We have a cluster of folks, but we did also sample nationally. And on the right-hand side panel B, you see that we have a nice distribution across the entire SVI, Social Vulnerability Index, from 0 being the least socially vulnerable all the way to 1, which is the highest social vulnerability. So you see we have a representation across the spectrum. And so one of the things we wanted to do is a manipulation check, because we know that historical policies and social constructs have led to racial disparities, and in particular, Black-white disparities in housing. And right now we see that when you look at just comparing Black versus white participants, that we do see a robust difference in the social vulnerability index of the census tract that they're part of, with Black participants showing higher social vulnerability. And this is roughly a quarter of a percentile, or sorry, 25% in terms of a difference. When you break it down across the different subcategories, you see that these differences are mostly maintained, with Black participants continuing to be part of neighborhoods that have less resources and therefore more socially vulnerable. We also broke this down by the highest versus lowest social vulnerability, looking at, on the y-axis, clinically significant insomnia. So look, this is more severe, on the more severe side. And you see that while there are racial differences across both, you see that the racial differences are actually magnified in neighborhoods that are the most socially vulnerable, which is also important information. So to our main analysis, we were really interested in looking at are racial disparities in insomnia really explained or mediated by neighborhood characteristics? So we did see that, as we saw before, that there are racial differences, Black-white differences in insomnia severity, with Black individuals, participants showing higher severity. But we did see the mediation effect, the indirect path through social vulnerability, which led to a loss of significance of the original C pathway C, race to insomnia severity. And we also saw that just under a third of the variance could be explained by social vulnerability index alone while controlling for covariance. So how meaningful are these effects? Well, we did see a coefficient of 0.18, which technically is small, but if you look at the effect size compared to other established social or structural determinants of health, in this case, I'm showing effect size of BMI to neighborhood characteristics. You do see that the magnitude are comparable to well-established relationships in other domains. So you'll see I've highlighted a presence of a convenience store within proximity was a 0.16 effect, and perceived lack of safety during night and day was a 0.18 effect. So our effects are relatively comparable to some of these other effects. So these are not smaller effects compared to other domains. And of course, we can do fancy statistics on these differences, but really, if you just look at neighborhoods, and this is a famous division line in Detroit, you can see, right? You don't need fancy statistics to see that there are clear neighborhood differences, and sometimes these are stark, right? If you squint, you can draw a clear line, and in fact, there's a clear road that separates the houses that are much more densely populated versus houses that are on large acres of land with lots of greenery, and you see clear differential in terms of the distribution of white versus Black individuals in these respective neighborhoods. And these don't just come about by accident. These come from years and years of practices, policies, mortgage redlining, et cetera. So I'd like to offer that in addition to a sort of a two-dimensional approach of thinking about socio-ecological frameworks, we also should understand that these frameworks have a whole lot of history and practices behind them. And this is important because it speaks to how malleable these constructs are and what are the respective factors that we want to consider if we want to get into, for example, structural interventions. So with that, let me just thank my collaborators, my funders. Thank you all for your attention, and I look forward to questions at the end.
Thank you so much. So now we'll move to Dr. Troxel.
Well, it's an absolute pleasure to be with you here today to present our team's work on the sustained impacts of neighborhood investments on sleep health over a 5-year period. I'd like to acknowledge my co-authors and team members on this work, and of course, Sleep Health and the National Sleep Foundation for putting together this truly special issue and for giving me the honor of presenting as part of this webinar with these other amazing colleagues. Substantial research demonstrates that our zip codes matter for our health nearly as much as our genetic codes. And this may extend to our sleep. Now, while extensive research has examined how where we live and place impacts other health behaviors like diet and physical activity, much less research, present company excluded, has focused on the role of the environment on sleep. My team at RAND and our external collaborators have leveraged an ongoing natural experiment called the FRESH study, which is designed to examine how changes in neighborhood conditions, spurred by a number of public and private investments, impact a variety of resident health outcomes in two historically disinvested and predominantly Black American communities in the city of Pittsburgh. Just to give a little history on FRESH, FRESH began with one specific natural experiment and one specific health focus. Does the elimination of a food desert via the opening of a full-service supermarket impact residents' diet and obesity-related outcomes compared to a sociodemographically similar comparison neighborhood that did not get a supermarket? This work was led by Dr. Tamara Dubowitz, who's now at the University of Pittsburgh, and that's another fascinating story best told by Tamara for another day. Returning to our story, as we continued to follow the FRESH cohort and these neighborhoods, we quickly learned that neighborhood changes rarely occur in isolation. And in fact, between this time we started tracking these two neighborhoods, the Hill District and Homewood, in 2011 and through 2018, there were considerable additional investments in the intervention neighborhood, that's the Hill District in dark blue, relative to the comparison neighborhood, the Homewood neighborhood, which is in light blue, about twice the dollar value in investments. Now, what's important to note is, neighborhoods are also not perfect controlled experiments. This is truly a quasi-natural experiment because while Homewood or the comparison neighborhood did receive substantially fewer investments and significantly lower dollar value investments as compared to the intervention neighborhood, it wasn't a static situation either because neighborhoods are dynamic over time, and that's important to remember as we conduct this work. So we leveraged this differential investment to address the question, does changing neighborhood conditions matter for sleep health? Or in other words, does investing in a neighborhood that could be characterized as a sleep desert improve sleep health among residents? The sample for this study is predominantly comprised of older African-American adults. As you can see from this summary of demographics at baseline, the sample is low income, around 55 years old, and by design, there were no sociodemographic differences in the two neighborhoods at baseline or over time. Residents across both neighborhoods also had high rates of being overweight or obese, as indicated by an average body mass index of around 31. Baseline assessments of sleep, measured via actigraphy, also showed poor sleep health across a variety of sleep health indicators. In this case, we're looking at sleep duration. And you can see that the vast majority of the sample is sleeping less than 7 hours per night. Only 16.7% of the sample is getting at least 7 hours of sleep per night. We examined an individual level indicator of exposure to any neighborhood investments occurring between baseline and the follow-up period based on one's proximity to any public or private investment. That is, residents living within 1/10 of a mile of any neighborhood investment project were considered near investments. In this and in future results slides, that is the blue lines. Those living further from investments, that was characterized by those living greater than 1/10 of a mile or about a city block away from any public or private investments. Those will be the orange bars. Primary outcomes included changes in sleep over time, over a 5-year period. Specifically, we measured sleep in 2013, 2016, and 2018 via actigraphy and sleep diary. Our outcomes included actigraphy-assessed sleep duration, sleep efficiency, and wakefulness after sleep onset, or WASO, and diary-assessed sleep quality. In previous published work led by Tamara Dubowitz, we found that over a 3-year period, residents living closer to neighborhood investments experienced better sleep health over this shorter term, including measures of sleep duration and continuity compared to those living further from investments. However, we hypothesized that investments may impact sleep differently in the shorter versus longer term. So the purpose of this study, and here I just list some examples of how investment dynamics may play out differently and impact sleep differently over time. So given the potential differential impacts of investments over the short versus long term, depending on when various investments came online, the current study sought to extend our prior work by examining the sustained impact of neighborhood investments on sleep outcomes over a 5-year period. And these plots summarize our current findings. Again, blue lines indicate residents living closer to investments, orange lines are those living further from investments. The overall pattern of results you can see is that regardless of exposure to investments, there's a general worsening of sleep over time, which is likely due to the fact that this is an aging cohort. However, over the 5-year period, those who live physically closer to investments experienced significantly smaller decreases in sleep efficiency and smaller increases in WASO, and marginally smaller declines in sleep duration relative to those who lived further from investments. There was no difference in sleep quality between the groups. And to summarize, these results demonstrated some sustained benefits of neighborhood investments over time on sleep. As I mentioned, residents living closer to investments tended to show sort of better indicators of sleep continuity measures over time. There were no statistically significant differences for sleep duration or sleep quality over this more extended period. And overall, findings were somewhat less robust than our shorter-term findings. Importantly, given that both groups showed worsening sleep overall, which may reflect age-related sleep declines, findings suggest that investing in neighborhoods might at least partially mitigate age-related sleep deterioration in older communities. More broadly, this study challenges the notion that sleep health is driven solely by individual behaviors and routines. It's also about living in an environment that supports healthy rest and recovery. By improving the environments in which people live and sleep, policymakers and community leaders can help reduce health disparities and improve health outcomes for all residents. And specifically by reducing sleep deserts through thoughtful and, importantly, community-informed investments, we can help ensure that everyone has the opportunity to sleep well, live well, and age well. And with that, I'd like to acknowledge our grant funding for this work from the National Institutes of Health, and of course, my collaborators from RAND, University of Pittsburgh, Stony Brook, and Arizona State University. And I'd also like to extend my sincerest thanks to our participants and our amazing community-based data collectors who make this work possible. Thank you.
Thank you, Dr. Troxel. So I want to thank all the speakers for presenting the research, but most importantly, for actually conducting this very important research that clearly has implications for improving sleep and population health. So for our audience, please feel free to use the Q&A feature to ask your questions. And so while I wait for some questions to come in, I want to highlight some novelty that I saw across the different presentations. So Jing, it was really great to see some evidence around the indoor environment, since most of our work has been at the neighborhood level that we see in the field. Bill, I thought it was really striking to see that 31% of the racial disparity in insomnia was partially explained by the neighborhood environment, which shows targeting perhaps some of those features of the social environment might be a great avenue, a strategy for reducing disparities in insomnia. And Wendy, it was really nice to see, leveraging methods around natural experiments to really, again, leverage that investment that's happening and seeing how that affects sleep over time, and having 5 years evidence is great, particularly because most of this work has been observational in nature. So to see an actual or implication of an intervention, particularly around investing in a neighborhood, could really be beneficial for improving sleep. So I would love for you, Isha, speak to your thoughts around how this work can be leveraged in order to reduce disparities. And why don't we start with Dr. Troxel and we'll work our way back. And there's lots of questions coming in, so I'll move to the audience after you answer that question.
Yeah, well, thank you again. This is, I think, the really important and exciting part of this conversation. At least I can say in terms of our work moving forward, I'm really interested in, developing and implementing multi-level intervention strategies. What this work clearly showed us is that, structural and broader policy level interventions, including investing in neighborhoods, that matters for sleep. And I really want us to start developing interventions that actually implement across the socio-ecological model, multi-levels, operating at the policy level, operating in the households with families, with parents, within communities, and really looking at the intersections of these different levels, ideally simultaneously, as that is where I think that we'll get the greatest, bang for our buck and have the biggest impact on people. And also I want to continue to do work, and I think it's so important in terms of our lessons learned, that the types of interventions that we do need to be very much sort of culturally grounded and relevant and community informed. So, really finding out from the community, what are the strategies or the perceived barriers currently operating at these multiple levels that we could intervene on, and then using that input to develop our interventions.
Well said. Thank you. Dr. Cheng?
Yeah, I would love for the insomnia space to start to incorporate some of these structural pieces into our thinking, and then also, of course, into our treatment. So we roughly have two tools. We can use cognitive behavioral therapy for insomnia, which outside of basic sleep hygiene, does not really account for social and structural factors. And then we have sleep medications, which of course also don't address these factors. And in some of our qualitative work that has been done in lower socioeconomic status communities, we are finding that things like sleeping arrangement, housing type, bedroom type, and also neighborhood level concerns about safety and whatnot, just sort of as a broad net, are factors that people are talking about. And, we can use sleep restriction to kind of make them drive up the sleep homeostat and help them sleep. But at the end of the day, these factors are still going to be relevant. And I believe they impact whether or not folks can even engage in some of our treatments to begin with. So I would love for our frameworks to start to shift and be more encompassing of these social and structural factors.
Absolutely. Jing, would you like to add to that?
Sure. From my opinion, I would like to have like a two-stage approach. So first, I would like to like expand my some investigations to a wide range of the environmental factors, like not only the indoor for my study, like I take a look for the indoor air quality, but there are also some different like indoor characteristics like the light or the human activity, and also the neighborhood level environment or the social ecological level of the environment. Those are all very important components. So after we like have a more comprehensive understanding for the determinants of the sleep health, we can integrate them together to see like how those each of the components and also the different components interact with each other to influence our sleep health. Then I would like to like it will give us some sense on like what specific components we should be targeting to then to develop some interventions. So for example, from my study, I would like to highlight some potential intervention solutions to improve our indoor air quality, like it do not need to be very fancy or complicated. We just need to give the parents, for example, some low cost sensors, and we let them to see the real-time value on the screen, then they will get some real-time feedback. They may alter their behaviors, so they may change. They might have some like potential to reduce their indoor pollution, and it also be worth to like give them some like education intervention or improve or from the policy level, like to strengthen the building code of the housing and also like some smoking or like cessation policy to improve their like housing conditions. So that's my thoughts.
Thank you for that. Okay, so I will present some of the questions from the audience, and if you could potentially keep your responses, short, so we can get through as many questions as possible. So the first question is for Dr. Cheng. So your research that you presented focused on Black and white individuals, and so the question is, do you expect or think that the results would be the same, and if not, what may be different if you include other brown populations such as Asian individuals?
Yeah, that's a fantastic question. I think that there are going to be some shared forces. And I also have to appreciate that there are some real meaningful differences in the ways in which specific communities are minoritized. Specifically in the Asian, which sometimes are brown as well as maybe East Asian, there are forces around the model minority myth that I think does present unique challenges to mental health. And that these have sort of different historical contexts in terms of like mortgage redlining and structural discrimination that I think are really meaningful and that we need to unpack before we start to generalize between different minoritized populations.
Thank you. So the next question is for Dr. Troxel, and it, actually kind of is thinking about some of Phil's work that he presented in terms of the outcome of insomnia with your work. And so the question is, from actigraphy, you were able to identify a WASO type of insomnia. And so the person is asking if you have any data on, some other questions popped up and it moved it. If you have any other question or other data on other measures of insomnia, such as sleep onset latency or early morning awakening type of insomnia?
Yeah, our study was really focused on sort of sleep health more broadly, as opposed to more discrete sort of sleep disorder categories. We do have other measures that were collected at different time points of sleep quality more generally, but we didn't distinguish. And actually, we probably we do have sleep latency from sleep diaries, but we actually haven't looked at that. But again, our approach has really been sort of focusing on general dimensions of or parameters that would be considered consistent with a sleep health framework.
That's fair. And so just as another question to you, um, and so they state in the natural experiments, have you examined structural mediators which may explain improvements in sleep health, such as changes in noise, light, or safety? And if you haven't, can you speculate a bit on that?
Yeah, that is an acknowledged limitation of this work and this publication, which we discuss in the paper, that we're not able to look at the actual mechanisms that might underlie these sort of sustained impacts or the lack thereof. That's absolutely something that we would like to do, that we would recommend doing in the future, but we didn't have a way in this study to really pinpoint. We had the sort of the dollar value of investments when they came online, but we couldn't actually disentangle that it was this investment that might have caused noise disruption at this time, but then impacted feelings of sort of neighborhood pride or cohesion at a later time point. Those are the things that we still really want to systematically unpack, but remain to be done. But a very important question.
Yeah, definitely. So this next question is for any of the speakers, if you have thoughts around it. And so as we talked about the population health implications, but there's also policy implications for all of the work that was presented. And so the question is, do any of the speakers have thoughts on how best to partner with HUD or policymakers and policymakers to promote healthy homes and healthy neighborhoods?
Okay, if I jump in on this one.
Please.
Yeah, I've been thinking about that question, and I think an example that comes up more recently are these recommendations to move from gas stoves to induction cooking. And Jing, in your presentation, I saw cooking, right, as one of the main sources of pollutants in the home. And I didn't sort of see and realize that there are cultural differences in terms of how food is prepared. And one main advantage of gas stove is being able to cook with high heat, whereas the induction stoves don't get as high heat. And these cultural differences, I don't think are well thought out in terms of the implementation and the education around sort of trade-offs for how to make these choices. So I think one way to do that is to really start to be more culturally tailored in the messaging when we're trying to roll out healthy practices in the homes. But Jing, I would love to hear your thoughts on that too.
Yeah, thanks. And from my opinion, I think one best approach like to promote the kind of policy implementation is to maybe select our study population. I think one step is like to cooperate, for example, the public housing, people who live in the public housing who I think the housing like is provided by the federal or the local government. So they may pay more attention to their living conditions, and I've seen some recent study published like some smoking cessation policy implemented in the public policy. They do like improve their people's health who live there. So I think that might be the first like step to get attention from the government or the people who have the resources to like improve the health disparities. Yeah, that's my thought.
I would just briefly add, I mean, I think one of the advantages of forums like this and other forms of messaging science that our impact does not just end in the journal article itself, that is really incumbent upon us as we do this work to make sure our messages are getting out there in a translatable fashion to the broader community, including to decision makers at the local, state, and federal level, so that sleep health is an integral part of the conversation on health more broadly across the nation. And so that the message that sleep health does not begin and end in one's bedroom, but rather is influenced by these multi-level broader influences. That's where, you know, we really, as a community of scientists and sleep clinicians, can make a big difference if we put some of our effort towards messaging towards that broader audience.
Yeah, thank you for that, Wendy. I totally agree. I think in the same way that we promote our research and seek out collaborators, we have to do the same with policymakers and others that are working in this arena. So being persistent and sending out information and having these conversations is a really great start. There's lots of community organizations that are doing work to improve neighborhoods. And so reaching out to those. So, for example, I'm in Atlanta and we have purpose driven communities, which are neighborhoods that are driven to promote health and address social determinants. And so I think an email goes a long way to just talk to these individuals and make sure they're aware of sleep and how they can incorporate that in their designs and builds of the environments. So I think this will be the last question that we present. Thank you all for sending questions, and I'm sure you can email the speakers if you have additional. So this last question, I think really kind of challenges the thoughts that we have around just focusing on risk and really thinks about resilience. And so they're asking, and thinking about sleep health as this holistic approach that's not focused on problems per se. So they're wanting to know if any studies have focused on super sleepers, those who are able to maintain good sleep despite poor neighborhood conditions. And I would highlight, those that are perhaps resilient in these environments. So despite being in circumstances that are adverse, they're continuing to thrive or have a faster bounce back or recovery. So they're asking if any of these studies have focused on those super sleepers. In in so that's one question. If you have focused on that, and then secondly, if not, if we could learn anything from this group of individuals to inform our approach to improving sleep health for those that are most at risk.
I'll just say very briefly, I think it's a brilliant question, and the focus on resilience and thriving in life via thriving in sleep is such a neglected area and something that I definitely want to be doing more of. Unfortunately, in our population, I don't think we had any super sleepers. This was a population very much enriched for sleep disturbances and other health problems. However, in some other work we're doing, I think, it's not just a good idea or sort of a light and fluffy idea to focus on the positive side of things. It really matters for communities, and it is a part of strength-based approaches to intervention, which we need to be doing more of. And I can speak to our work in American Indian, Alaska Native populations, not the focus of this current study, but some other work we're doing. In that work, we really are trying to, focus on resilience factors, including cultural connection, engagement in traditional practices that might have calming or soothing effects that could be beneficial for sleep, and then integrating those as part of a strength-based approach to developing culturally informed interventions. So more to come on that.
Thank you. Any other speaker want to? Oh, yes, Phil. Sorry,
Yeah,
I didn't see your hand.
I just want to also say I completely agree with Wendy, and we also need to be really thoughtful about what we mean by super sleeper, because a lot of times people will say, "Oh, I can sleep through anything. I can sleep through a hurricane." which is not normal and sometimes is
Yeah.
reflective of an underlying sleep disorder like obstructive sleep
Hmm.
apnea or something. So you can look like you're a super sleeper, but really what it is excessive daytime sleepiness.
Hmm.
So absolutely, we do need to have more strength-based approaches, but also understand that we have to identify strengths at real strengths as opposed to a
Yeah,
byproduct of something else.
I totally agree with that. Now, I also want to highlight focusing on health promoting factors that may be modifying the association. So perhaps, individuals that have more social support or live in areas with higher social cohesion, even though there may be more violence and so on in that neighborhood, that may be buffering the effect. So having our research focus on potential modifiers will also be really important for advancing sleep health equity. Okay, I am sorry that we did not get to all of the questions, but I am really happy that we were able to answer many of the questions that were presented and hear this wonderful work that's being conducted. I want to encourage all of us to continue this work and really hone in on these populations that are experiencing poor sleep health and sleep disorders that shouldn't due to these avoidable and unfair circumstances. So, again, I would like to thank our presenters for being here today. I would like to thank all of you that submitted articles. Thank all of you that have articles that are featured in this special issue. So please run over to the Journal of Sleep Health and download the issue. I look forward to continuing this conversation through social media as well as through other avenues. So thank you again for attending the webinar, and I wish you all restful sleep.